treatments. Dr. Malwinder Singh, Sandhu.
Thank you, Mr. Chairperson. Good morning, everyone. I would like to thank the Bangladesh Oncological Club for giving me this opportunity to present a little bit about prostate cancer. Okay, so these are my disclosures. I'm heavily involved in a lot of these pharma companies for prostate cancer trials, but I'll try my best to give a non-biased talk for today. Okay, so what is castrate-resistant prostate cancer? So you need to fulfill 4 different criteria. First, you need to be on ADT. Second, you need to progress on that ADT with 2 consecutive PSA rise. Testosterone level has to be measured, and you have to do imaging. Either it's conventional with a CT scan or a bone scan, or you can proceed with doing a novel scan like a PET PSMA. Now, in 2025, we need to define castrate-resistant prostate cancer into non-metastatic and also metastatic. Still, again, you can do it with conventional imaging or novel therapy, a novel agent. So the definition of non-metastatic castrate-resistant has to be divided into 2, whether it is low risk or high risk. So if you are low risk, your PSA doubling time need to be about more than 12 months, and if you are high risk, it has to be less than 12 months. Now, why is this important is because if you have a patient whose PSA is rising slowly, you do not need to treat them actually, unless their PSA doubling time is actually very rapid, which will actually bring them a poorer prognosis. Now, whether you use 12 months or 10 months, it depends which trial you actually choose. So there are 3 trials which is supported by the pharma company, and they produce a landmark trial with Enza, APA, and also darolutamide, where their endpoint was metastatic free survival, and all of it hit their endpoint. And based on FDA, a definition of high risk is actually PSA doubling time of less than 10 months. Now, all of them actually have a positive results in terms of metastatic free survival and also overall survival. You're looking at about 0.69 to 0.78, and it is the standard of care right now to treat them with some ARPI, either APA, Enza, or darolutamide, if they are non-metastatic castrate-resistant. Now, let's look at the guidelines, whether you're looking at ESMO, AUA, or also EAU. European or American, all actually supports these clinical trials where they say if your PSA doubling time is actually less than 10 months, you should start them on ARPIs. Okay, now bear in mind, most of these clinical trials are using conventional imaging. So they do CT scan or bone scan. But in reality, PET PSMA is actually gaining some traction. So even in my country, in Malaysia, I would say roughly about 20 to 30% of patients actually go through PET PSMA, but still about 70% are still doing CT scan and also bone scan. So in 2025 now, we are like small childs. We have a lot of new drugs to play. We have a lot of new imaging to do. So it brings us a lot of light. So there's options of doing PET PSMA, there's options of doing whole body MRI, pelvic MRI, bone scans. So what actually happened in St. Gallen's APCC consensus meeting, where they actually presented to the panel, if patients who have non-metastatic castrate-resistant on conventional imaging, that means negative on CT and bone scan, what would they suggest next? So 74% of the panel actually suggest that they should do a next generation sequencing, either a PET PSMA whole body MRI, or they combine pelvic MRI with PET CT, or pelvic MRI with whole body MRI, or CT plus MRI and bone scan. Okay, so this is actually what I would suggest what is actually available in your setting. Like in my setting, I work in the private sector, so I have PET PSMA on my disposal. So most of my patients will actually do PET PSMA. But in the public setting in my country, most of them will just do bone scan and also CT scan. Now, one thing what they asked in APCCC also, if say you do a novel imaging scan and you actually found less than 3 lesions, what would be your next suggestion? 3 to 5 lesions, sorry. So majority of them actually support to treat with metastatic directed therapy, either surgery, radiotherapy, or any other local therapy with some systemic treatment. Some of them do not start systemic treatment, but they go ahead and do some metastatic directed therapy, and some of them straight away just change to systemic therapy. Now, this is a very beautiful trial from Italy, especially with a very small population, where they categorize them between less than 3 non-visceral metastatic disease. So what they did was they gave abiraterone plus SBRT to the lesions versus abiraterone single agent. Now, in their overall, in their final analysis, Sorry, my mistake. So in their analysis, they actually found that there's actually PFS and also overall survival. However, the final analysis is still not matured yet, so we need to wait for the final analysis. And I don't think so the overall survival will be matured at the end because it's a very small trial, and it's also a very small population inside that group. Okay, so that is about non-metastatic setting. What about the metastatic setting? So we categorize them as historical metastatic castrate-resistant prostate cancer. So back in my country also, I would say roughly about 50 to 60% of our population are being treated with just ADT alone in the castrate-sensitive setting. We do not treat them with ARPI because of the public funding, but those who can afford themselves, so they go ahead and treat with ARPI in their metastatic setting. So these are all the systemic therapies for metastatic castrate-resistant prostate cancer, which has overall survival benefit. So we have chemotherapy from docetaxel, cabazitaxel. We have ARPI in the pre-chemo and post-chemo setting like enzalutamide, abiraterone. We have theranostics like radium and lutetium, and also PARP inhibitor such as olaparib or talazoparib, and also niraparib. And also not to forget our bone modulating agents like zoledronic acid or also denosumab. Okay, several agents has been approved for metastatic castrate-resistant prostate cancer, but our main issue is the sequencing. Okay, and most of these trials, their standard of care arms was actually mitoxantrone, prednisolone, ADT, which is not actually the standard of care at this current moment in 2025. And most of these patients was just treated with ADT alone in the castrate-sensitive setting. So now when we see patients in the clinic, we will have 4 different scenarios of patients to treat. Group 1 will be patients who are treated with ADT alone, which is majority of the case in metastatic hormone-sensitive prostate cancer. A second group where have already done some chemo, docetaxel in the metastatic hormone-sensitive. Third will be ADT plus ARPI in the hormone-sensitive. Once they progress, what do you do next? And the latest one, the triplet therapy in hormone-sensitive, they have already tried ARPI and also chemo. So what would you do next after they come to your clinic when they progress? Okay, the evidence is very clear for patients who just had ADT, and when they progress to metastatic castrate-resistance, you have abiraterone and enzalutamide from the pre-chemo and also the post-chemo setting, where you're getting a hazard ratio of about 0.74 to 0.81. Now, it is very clear, but what about if we want to add on some PARP inhibitor? So we always like to do a lot of combination treatment. Combination treatment tends to give a better response, but some are positive trials and some are negative trials. So we have one clinical trial which was presented in ESMO 2022, is PROPEL. So these are for first-line metastatic castrate-resistant prostate cancer. They can go for docetaxel in their hormone-sensitive setting, and 2 arms. One arm was abiraterone plus olaparib, and the second arm was just abiraterone alone, and their endpoint was radiological progression-free survival. Now, in the intention to treat population, it looks like it has positive data, about 24.8 months versus 16.6 months. But in reality, it is actually heavily driven by the BRCA mutated patients. So you can see in the BRCA mutated patients, the PFS was not reached versus 8.4 months. Hazard ratio was 0.23, which is actually very, very good. And I just want to show your attention to the slide also. If you look at the comparator arm, for patients who are BRCA mutated, they actually fall into the poorer prognosis. Their PFS is roughly about 8.4 months if they just treat with ARPI, okay, versus if you are actually on non-BRCA group, it's about 19 months. So if you have a patient with BRCA mutation positive, you should always try to start PARP inhibitor earlier on. Overall survival was not significant, but in the subgroup analysis, you can see that actually it was significant. Magnitude is another trial which is similar in design as the PROPEL, but they were using niraparib and abiraterone in BRCA1 and BRCA2, which has PFS but no OS benefit. And same thing like TALAPRO-2, where they tried talazoparib and also enzalutamide in the HRR deficient, where we actually do see that there's OS benefit in the HRR subgroup. Now, one thing which we need to bear in mind, all of these PARP inhibitor trials was initially started for all comers. Because scientists tested in vitro, they found that actually PARP inhibitors work for metastatic HRR or BRCA mutated patients. So they brought in all comers. But if you actually look at every single trial, the one who actually benefit the most are those who have HRR mutated or also BRCA mutated. So if you do not have that, try not to use all this PARP inhibitor. Okay, combination treatment is great, but one of the main problem is the drug discontinuation rate. So if you have a combo regime between ARPI and also PARP inhibitor, it brings in more toxicity compared to just treating them with ARPI alone. So this is a small algorithm which I actually did. If a patient was treated with ADT alone in the hormone-sensitive setting, if you are non-BRCA mutated or BRCA positive, you can treat them with ARPI, abiraterone or enzalutamide. Or if they are BRCA mutated and HRR positive, you can treat them with combination therapy, abiraterone plus olaparib or niraparib, and enzalutamide plus talazoparib. And when they move to the second line, you can treat them with some chemo or some theranostic therapy. And also don't forget the bone modulating agents. Okay, this is a trial by ERTC called PEACE-3. So these are for bone metastasis, no visceral mets, where they went ahead with 6 cycles of radium plus enzalutamide versus enzalutamide alone. It's a very good trial which actually have PFS benefit and also overall survival benefit. But one of the critics was the initial curve was actually crossing each other. So FDA have not approved theranostic combination with ARPI at the moment. They are waiting for the final analysis. So we have another trial of ENZAPI, where patients was stratified between lutetium plus enzalutamide versus enzalutamide. This was a small trial by the Australians, and also similar thing, it has PFS benefit, OS benefit, but still it's not FDA or EMA approved because they are still waiting for the final overall analysis. So if you have a patient with ADT plus docetaxel in the hormone-sensitive setting, so what are the possible algorithms which a patient can go through? If you're BRCA mutated, you can go for abiraterone plus olaparib or niraparib, enzalutamide plus talazoparib. And if you're non-BRCA mutated or HRR mutated, you can actually go for abiraterone or enzalutamide. Now you can also use chemotherapy in this setting like cabazitaxel if your patient is very, very symptomatic. And then in second line, you're left with lutetium or cabazitaxel or even some chemo where we actually give carboplatin for some patients if your PARP inhibitor is not available. Okay, so ADT and ARPI for hormone-sensitive setting. Now once they progress on that, if they are BRCA altered, should the patient go through chemo or actually go through a PARP inhibitor? So there's this trial from Triton-3 where they actually had patients categorized between PARP inhibitor rucaparib versus chemotherapy docetaxel or second generation ARPI, which we call it switch therapy. Now, I would say probably about 3 to 4 years ago, NCCN guidelines do recommend switch therapy in their protocol. But I think over the last couple of years also, they have already removed the switch therapy option because in reality, in clinical practice, even in my clinical practice, I see patients who go through switch therapy, their PFS is not very, very great. So you're looking at roughly, if you look at this post-trial, you're looking for switch therapy is about 4.5 months, which we see in our real clinical practice also. Okay, so if you have rucaparib, you have better PFS in the BRCA mutated compared to chemo or switch ARSI, about 4.5 months. In the switch therapy, so we really don't recommend switch therapy at this moment. Okay, what about another group who's actually not BRCA altered? Should docetaxel or lutetium PSMA be given? So this is a trial called PSMA-4, where it is actually patients who have confirmed progress on metastatic castrate-resistant, where you're actually a candidate for a change ARPI, or you have progressed on a second generation ERPI. Now in this trial, about 19% of patients actually had ARPI in the castrate sensitive setting, okay, and not a candidate of PARP inhibitor. So what they did was they stratified them between lutetium versus ARPI change. So similar thing what I mentioned, if ARPI change, mostly your PFS is going to be about 4 to 5 months. So in this trial was 5.59 months. But if they have lutetium, it's about 12 months, where you're looking at almost double of the PFS, radiological PFS. Now, in the updated overall survival, we did not see any significant findings, but it's mainly because about, I think it was 50 to 60% of the patients actually had a crossover. So if you have a crossover in clinical trials, it's very hard to prove an overall survival benefit. But what is interesting is the time of worsening of quality of life. So if you have lutetium therapy, your quality of life is actually much, much more better. Okay, so if someone who had ADT plus ARPI in the castrate-sensitive setting, their possible algorithm, if they are first-line non-BRCA mutated, they actually go for docetaxel or theranostic therapy. If they are BRCA mutated or HRR mutated, they actually go for olaparib or rocaparib. Docetaxel again if they are actually very symptomatic. Then second line, they can actually have lutetium or chemo, or just chemo plus lutetium in both arms. Now, one thing very interesting in the APCC also, where they actually ask for a poll. If a patient who have tested negative for hormone recombinant repair mutation or even BRCA, where it's actually negative, and those who have actually failed on ADT plus ARPI in the metastatic setting, what would you recommend? Whether is it lutetium or just chemo? So majority of them actually recommend chemo compared to giving theranostic therapy. Now, bear in mind, this is also because when this consensus was taken, the PSMA-4 data was not presented in this setting. That time, the quality of life data was not presented. So it might change right now, but we really do not have the answer. Okay, what about for patients who actually have prior triplet therapy? Now, in this setting, we really do not have any evidence to prove. If this is what my suggestion is and what expert consensus have. If you are BRCA mutated, you actually go for PARP inhibitor. But if you are non-BRCA non-mutated, you can actually go for theranostic therapy or cabazitaxel, and also the bone modulated agent. In APCC also, the same thing was asked for patients who have tested negative for HRR or BRCA, and they have already had triplet therapy in the hormone sensitive setting, what would be your option? Majority of them actually supported lutetium therapy, followed by chemotherapy. Now, so in conclusion, what my presentation today is treatment monitoring and careful selection of sequence of therapies is important. So sequencing will determine the longest survival for a patient. Again, it depends on what drug is available in your country. Like in my country, we have a lot of originator and we have the patent law, so we do not have a lot of generic drugs, so cost is always an issue. But when I was walking down in the booth, I saw a lot of generic companies having a lot of these novel agents. So I think it's good that you guys actually have the generic versions here. Now, do not rely on PSA alone for treatment decision in men with metastatic castrate-resistant. You still need imaging to see whether you can actually give some metastasis-directed therapy. Now, do not change treatment because of just an increase in bone lesion. Do monitor them, because we do see sometimes if you do conventional imaging, it might not be accurate. Unless you're doing a PSMA PET, you can actually see the uptake changes. And whenever possible, include your patient in clinical trial to give them the latest treatment. Now, treatment of metastatic castrate-resistant prostate cancer is driven by what they have received in the castrate-sensitive setting. And treatment decisions will always depend on the patient's alteration of the BRCA and also HRR mutant. So please test the patients for those things. Several treatment options is available, but the optimal sequencing is not clear. Only a few selected patients with MSI high can actually profit from immune checkpoint inhibitor. And do not forget the bone targeting agents. Thank you.
Thank you, sir. Now, I would like to request our distinguished chairperson, Professor Dr.